Welcome everyone to the fifth and final installment of our Implementing High Quality Primary Care webinar series. Every Tuesday this month, we focused on a different theme of the new National Academies report, Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. In the previous webinars, we discussed payment reform, access to primary care, workforce and training needs, and digital health tools. This morning, we will be discussing federal leadership, research, and the accountability mechanisms that are needed to ensure that high-quality primary care is implemented in the United States. I'm joined by a fantastic group of committee members and panelists who I want to introduce to you in just a moment. After that, we're going to have a brief presentation summarizing the report content related to accountability, and then we'll move into a discussion with our panelists before taking questions from the audience for the remainder of the webinar. A recording of this event and the slides we present will be available online after the event concludes. So I'm Bob Phillips. I'm the founding executive director of the Center for Professionalism and Value in Healthcare at the American Board of Family Medicine. And I'm joined today by my co-chair of the committee, Linda McCauley, Dean and Professor of the Neil Hodgson Woodruff School of Nursing of Emory University, and Chris Kohler, President of the Milbank Memorial Fund. With us today, we also have our panelist, Kathleen Sebelius, who served as President Obama's cabinet as Secretary of the Department of Health and Human Services, where she worked to pass and implement the Affordable Care Act. At Health and Human Services, Sebelius managed 11 operating agencies, 90,000 employees in 50 countries around the world, and a $1 trillion budget. Before her role as secretary, she was elected to statewide office 4 times in Kansas as governor and insurance commissioner. Currently, she is the CEO of Sebelius Resources, LLC. Joining her is Richard Frank, who is a Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard Medical School. From 2009 to 2011, he served as our Assistant Secretary for Planning and Evaluation. And from 2014 to 2016, he served in this role in the Department of Health and Human Services as well. Before that, he served as a special advisor to the Office of the Secretary at the Department of Health and Human Services and the Deputy Assistant Secretary for Planning and Evaluation, directing the Office of Disability, Aging, and Long-Term Care Policy. And our final panelist is Sheila Burke, who served for 19 years on Capitol Hill, including in roles as Deputy Staff Director of the Finance Committee, Chief of Staff for Senate Majority Leader Bob Dole, and Secretary of the Senate. She currently chairs the Government Relations and Public Policy Group as a strategic advisor at law firm Baker Donaldson and serves as a faculty member at the John F. Kennedy School of Government at Harvard University, where she teaches legislative and regulative health policy. So we're grateful to have this esteemed panel, looking very forward to the conversation, and I'm turning over the discussion to Chris Kohler, who will cover our committee actions on accountability. Thank you, Chris.
Thank you very much, Bob, and thank you to folks in attendance for showing up and to our guests today. My role will be to overview the 5th and final objective that is outlined in the NASM report, Implementing High Quality Primary Care, that on accountability. Next slide, please. So just by background, we just have a few introductory slides. National Academy of Science, Engineering, and Medicine study members are selected from the public based on their experience and particular expertise for the subject matter. These are the committee members who served on this committee. I want to note that Brenda Rice Brennan, I believe, is on this call, and there may be others joining us as well. They represented a diverse set of experiences, including clinicians, researchers, people with insurance backgrounds, public officials. From a personal standpoint, it was a pleasure to work with a committed group of people working hard on an important question. I also want to thank Bob and Linda for their skilled leadership of the committee. Next slide, please. Oh, and I should also thank the National Academy staff members. You saw their names in small font at the bottom, but they really were the people who did all the work and made it go. This was a statement of task that we were charged with to develop an implementation plan to build upon the recommendations of the 1996 IOM report to strengthen primary care services in the U.S. and to inform primary care systems. The key part that was in the statement of tasks that was different from the 1996 report was an implementation plan. And we'll talk about this a bit more, but it assumes the value of primary care in a healthcare delivery system and asked the committee to look at the evidence about what was necessary to implement high quality primary care. Next slide, please. To do that, first, the committee had to agree on a definition of primary care, which is a moving target as research increases, as well as technology and what we know about population health. The committee notes three, if you will, additions to the sort of longstanding definitions of primary care. First, the focus on interprofessional teams rather than a clinician. The second, the focus on accountability for addressing the majority of an individual's health and wellness needs. And the third is this notion of primary care as a relationship between the clinical team and patients, families, and the communities, all of which have an effect on the health of individuals. So those notions of interprofessional teams, accountability, and relationships are significant additions to the definition of primary care that we have been tasked with developing an implementation plan for. Next slide, please. Fundamental to the committee's deliberations was the recognition of primary care's privileged status among healthcare services as a common good. Now, Professor Frank will correct me because I'm not an economist, but the definition of as I understand it, of a common good is one that is rivalrous, meaning more for one person is less for another because supply is limited, and non-exclusive, meaning that our fundamental public policies, our goals are to ensure that everyone has access to primary care. That's a value that if you look at EMTALA, we hold important as people should have access to basic care. So if it's seen as a common good, and part of this, I think the fundamental reason that it is privileged is that unique among primary care services, the committee found, unique among healthcare services, primary care is associated with and causative of improved population health and improved health equity. No other part of the healthcare delivery system can make that claim. That the committee determined merited primary care's particular status among healthcare services as a common good. But the committee notes that it is in precarious condition right now. Primary care in the U.S. is fragile compared to other healthcare delivery systems, and it's weakening. The committee produced documentation to show that whether you measure it in terms of workforce or in terms of dollars spent on primary care relative to others, primary care in the U.S. is weakening. As a common good, that requires public policy for oversight and monitoring, as well as advocacy, leadership, and public awareness to assist with that public policy. The implication is it's government's responsibility to steward common goods, and therefore the committee's actions have a strong tilt towards the role of government in shepherding this common good. And that just is a logical conclusion or extension of how the committee found the status of primary care to be. Next slide, please. So as Bob noted, for the last 5 weeks in these sessions, we have been diving into the 5 objectives that the committee identified for achieving high quality primary care. There is extensive work in the report, and we've discussed on these Tuesday mornings the committee's recommendations for payment, for access, for workforce, and for digital health. And today we're going to talk about accountability to ensure that high quality primary care is actually implemented in the US. This was not an objective that was, or an area that was discussed in the 1996 report. We think the notion of accountability is critical to the success of any implementation plan. Next slide, please. So when we think about accountability, as I said, the 1996 report lacked any accountability mechanisms. The U.S. has no organizing body for primary care, and it needs it both in the public and private sectors. An organizing body is one to develop an identity for primary care as a whole, high quality primary care as we've described it, and also to work for public policy change. On the research side, the committee notes that family medicine received about 0.2% of total research funding dollars. This in spite of the fact that primary care it accounts for 5 to 8%, depending on how you count it, of healthcare spending in the U.S., and 35% of the outpatient encounters in the U.S. So there's a fundamental inequity between what we spend on primary care and its role in our healthcare delivery system. And there's another research figure here of how the funded projects across all research agencies, not just for family medicine. Next slide, please. And then next slide. So the committee put forth 3 actions in this accountability section to implement high quality primary care as consistent with the notion that primary care is a common good in the United States. There is a strong federal role and state government, but primarily federal role in all of the objectives and the underlying action areas, and thus a need to ensure that those federal activities actually take place. After discussions and looking at the evidence, the committee recommends a role within the executive branch of a Secretary's Council on Primary Care, reporting to and accountable to the Health and Human Services Secretary, with a 3-part function to coordinate primary care policy across the various federal agencies, all of whom are the HRSA, the VA, the Centers for Medicare and Medicaid Services, federal OPM, and others, to ensure coordination of the levers that are needed to implement high quality primary care in the U.S. The second, if you will, authority that we're looking for within the council is that it have review capacity to ensure adequate budgetary resources are in the respective agencies to actually do this work of implementing high quality primary care. That line of sight into the budget is important to give the council authority. And the third is to report to Congress and the public some oversight and accountability mechanisms made public for how we are proceeding with this work. We're very much looking forward to the insights of our experts today around this recommendation. The next slide, please. The second action is targeted towards the relatively low levels of research spending that is the federal government expends on primary care. And so the committee recommends an Office of Primary Care Research established at the National Institutes of Health that reflects the importance that should be attached to the role of primary care in the U.S. healthcare system, and to prioritize funding of primary care research at the Agency for Healthcare Research and Quality as well. Finally, there is a need for external measures of accountability on the health of primary care. And so the committee recommends a health of primary care scorecard to be assembled and organized by primary care professional societies, consumer groups, philanthropies, and others who have an interest in high quality primary care. Next slide, please. A bit more about that scorecard. It is, or health of primary care report card. The criteria that the committee put forth is that we have selected measures that correspond to the actions that we are recommending, that they be few in number and easily understood and built on data that is regularly collected and publicly available, and that the entities that are held accountable are both the national and state governments and communities, because they're levers at both the national and state that can influence the health of primary care. So you see on the right-hand side how these are organized. Measures have been identified and organized by the objectives in the National Academy of Medicine report. Next slide, please. And this continues for the third and the fourth objectives as well. Next slide, please. So in summary, there are the 3 actions for the accountability section are to establish the Secretary's Council on Primary Care, with three primary responsibilities: to coordinate policy across HHS agencies, to have a line of sight to ensure that adequate budgetary resources are allocated, and to do public reporting, to formalize a home for primary care research and make an additional commitment to dollars for that research, and then to have an external accountability measure to measure the health of primary care in the U.S. in an ongoing way. These three actions we think are absolutely necessary to ensure that high quality primary care is implemented in the U.S. Next slide, please. I believe that concludes the presentation. This is, as you know, this is where you can obtain copies. And Bob, I'll hand it back to you and Linda, and look forward to the conversation. Thank you.
Chris, thanks so much for that pithy summary. Linda, I wanted to invite you to make any comments or observations before we move to our panel discussion.
So thank you, Bob, and thank you, Chris, for that summary. I think the scope of what the committee is proposing is very broad, but the problem that we're facing in the United States is a very broad problem. And we're charged with this implementation plan that today I think we're going to be talking a lot about the highest level of accountability with the federal government. But I also want us to remember that the status in the United States now that government is not seen as the answer to all problems. And the conversation today is very important, but I think also in the report, we lay out that there's macro level, the highest level interventions that are needed, but also there's important work that needs to be done at the state level and at the local level. The report is very centered on community engagement, and somehow we have to reach down to the community level and hear the voices of the public in terms of how they view primary care and what they believe about access to care. So you can pick up the report and read just the implementation chapter, but I encourage everyone to take the time to dive down into the chapters that talk about patient-centered, community-engaged care, the workforce, and the transformation of what it should look like. All these things hang together. So we could work on this. We could have webinars for another 6 months and not cover all the important things in this report. But I'm looking forward today to be focusing more on the macro level and how to launch this implementation plan. So thank you, Bob.
Linda, thank you so much. So just to come back to something that Chris said, so primary care is where more than a third of all healthcare visits happen, more than half of all outpatient visits. It is the only sector of our healthcare system that has an evidence-based relationship with equity and to improve life expectancy. And yet it wasn't part of our national epidemic plan if you look back to 2017, and certainly wasn't as we rolled out our efforts during the pandemic. And that was in large part a reason that the committee reached the notion that we needed some kind of coordinating function at a high level within the federal government. And so the Secretary's Council was, we thought, the best mechanism for that with existing authority. So Secretary Sebelius, we would welcome your thoughts about how do we make a Secretary's Council an effective agent of coordinating across agencies, policies, and other functions of primary care.
Well, thank you, Bob. And thank you all for this report. I think it's an important and incredibly timely topic. I need to also, though, throw a little cold water on some of the discussion, just because I think it's got to be placed in the reality of the situation. I was struck by the Avalier report that just came out, which confirmed what I think all of us are seeing in the market, which is that consolidation has continued at a breakneck pace during the pandemic season. And so now 70% of doctors in America are owned by either hospitals or corporations. Private equity has increased its share of docs in the workforce. So in some ways, I just share that because I think it kind of cuts against a little bit some of what we're talking about. We've got now 21% increase in the number of practices owned by outside entities. And if you think about either the corporate interests reporting to shareholders and where they're likely to go with primary care, and frankly, hospital interests in owning doctor practices, which lend to putting butts in beds, as I like to say, neither of those necessarily hit the sweet spot of what your report addresses of patient-centered, whole family wellness care, as opposed to other strategies. So I just want to also provide that. In terms of the Secretary's Council, I think it's a good idea. I think what makes it work is having interest inside the department in this happening. With all due deference, there are a lot of secretaries' councils. There are a lot of mandated offices with little siloed operations. What really drives momentum inside a big department like HHS is both the secretary's interest, the secretary's boss's interest, i.e. the President of the United States. So getting the White House attention, the White House Equity Council, the White House to focus on this, the secretary or key leaders in the department. And then I think the outside, the advisory committee and the outside advisors have a place to go. Absent that, I'm afraid to say reports can be filed and generate a lot of interest, but don't make much of a dent in the department. That's step one. Step two, I think, is a lot of conversation in the report is this multidisciplinary approach, which I think is great. Research needs to pay more attention at NIH and ARC. You need training to take place in the associations that do medical training. We need, team approaches. I gotta say, I think in some ways, although they're mentioned in the report, one of the models of this kind of care could be driven by federally qualified health centers that really could become family medical homes and approach this practice in a very different way. I think the components of all of that, they're driven with the federal budget. They're going to be expanding. They clearly are well positioned to deal with equity, already have a mandate that half the board has to be community members. So a number of the things that are mentioned in the report are already in place. But I think driving some models very quickly could be done through FQHCs in selected areas and look at whether or not the kind of measurements make sense. That's a way to really, I think, jumpstart this sort of effort and maybe jumpstart it within the department, because the pieces are already in place and you don't have to invent it going forward.
Secretary Sebelius, thank you. So I want to turn to Richard Frank for a moment. So Secretary Sebelius has pointed to FQHCs as a model and as a model that already has a policy and federal home in HRSA. They serve about 1 in 11 Americans at this point, and are a critical part of the healthcare safety net. And then you have primary care outside of FQHCs, which, as she also noted, is being driven to being owned. Most of the practices, the evidence is suggesting if Academy Health had it right last month with ASPE leading the panel, most practices remain fiscally underwater. Primary care is increasingly turning to larger organizations for their ability to survive. And many health systems are predisposed to take them on because it does provide a feeder mechanism for a fee-for-service based system largely. And we're in danger, the committee felt, of turning into two different kinds of primary care systems when we have an opportunity to create something more focused that has a policy home. And Richard, Frank, I wonder what your thoughts are about, if not a Secretary's Council, how do we help support, and or I should say, how do we prevent that dichotomy from happening?
Thanks for the easy question. Really appreciate it. Well, first of all, I want to say I agree with Kathleen 100% on her observations on Secretary's Council. The ones that, at least during my time in the department, that worked were ones that the secretaries were keenly interested in and really forced broad commitments across the department to make it work. So, but going more directly to your question, time where you see the Federal Trade Commission and the Antitrust Division of the Justice Department really tooling up. They're trying to hire, dozens of people. Their mandates have been expanded. I think it's very important to sort of start using sort of the competitive tools that we have at our disposal to sort of do a better job on preventing the kinds of consolidation that lead to some of the problems that Kathleen raised. I also think that certainly FQHCs are one toehold, but there are opportunities in Medicare and Medicaid to kind of promote this as well. So you've got, on the Medicaid side, you've got the Medicaid health homes, which are another institution that is set up at the community level, explicitly charged with including performance measures linked to community-based outcomes. And so I think that's another institution to build on. And I think as we see more and more experimentation in Medicare with alternative payment models, there are opportunities there in the way we measure it, in the way we set up the rules to promote the kinds of primary care organizational structures that the report talks about. So I think those are some of the most obvious levers, in my view. And like Kathleen, I believe that the place to start is to building on the institutions that are there and the financial and organizational levers that you already have.
And Bob, can I just jump in with Richard for a moment? I tend to listen to Richard and always agree with him. And that's one of the most effective ways to get this rolling. And a Secretary's Council could be very helpful. I just think you need to be realistic about how many exist. And, it's more important to get key agency officials to have interest in this than to spend a lot of time and energy creating a council. I would just say that they both could be simultaneous, but the interest has to kind of be organic. But secondly, I just want to remind people, I think the FQHCs are certainly not the only avenue. It's one that reaches out. Medicare and Medicaid are also huge. And now, as we see, Medicaid has over 80 million Americans as part of that beneficiary. Medicare continues to grow. So if you combine the three entities literally run by the federal government, you're reaching a broad swath of the public. But it was only through the Affordable Care Act that Medicare finally introduced a wellness visit. Now, you think about primary care and you think about an updated doctor review. That wasn't even part of the Medicare program until 2014, when those benefits, or I don't know when that particular benefit kicked in. It may have been one of the early adopters. So somewhere between 2010 and 2014. But, things like that. So the thought that primary care needs to be a kind of central focus, that you need to actually have a visit with a provider before you get really sick in order to stay well and look at those opportunities, which I think is what primary care is all about, is relatively new to, a lot of even the federal programs. So I think there's a lot of opportunity to drive equity and drive access, but it's not something that comes naturally, I think, in terms of federal benefits. They're all about when you get sick, what happens and what you can access, not how to stay well.
Thank you so much. I wonder, in conversation with some of the federal agency leaders, there was an observation that a secretary's council could help on an efficiency front. How with all the various silos, with payment policy in Medicare, and with HRSA overseeing FQHCs and some training program support, with ARC having congressional mandate to support primary care research, but not having any funding for that purpose. There are aspects of primary care that are already siloed across agencies and siloed within councils. Could this council perhaps be situated in a way that it could help improve the efficiency of what are now siloed efforts, so that payment policy can talk to healthcare delivery, so that research can talk to payment policy? Has a council been set up in that way to work across agencies and operate effectively? And I'll open that to the whole panel.
If I could, just building off of both Kathleen and Richard's comments, let me underscore the point that Kathleen just made, and that is, we're dealing historically with a system that was largely illness-based, largely based on things that occurred in institutions, and wasn't really directed towards keeping people healthy. I mean, that's the history of the Medicare program. To a certain extent, the Medicaid program, although its history with caring for mothers and children, a slightly different take. But the issue that you raise, which is the silos which exist, I don't think will be dealt with necessarily by the creation of a council. I mean, those silos exist for a host of reasons. I think of them in the context of congressional jurisdiction. Those silos exist because of the authorities that reside, because of the funding that resides. And simply saying we're going to put together a group of people in the absence of direction from the top, in the absence of an agreement upon what the outcome is going to be. Each of these are individual tools that have to be looked at individually, each of them enormously important. Medicare clearly as a purchaser sets the tone. Medicaid as a purchaser for 80 million people, it clearly sets a tone. The FQHCs are a piece of that, but it falls back to who do we pay? What do we pay them for? What value do we place on the services that they provide? And are we sending the right incentives in terms of how people are trained, where they're trained, by whom, and how we pay them to do what they do? So I think all of those things really overwhelm the creation of a council that essentially provides for an opportunity for people to talk. There are elements of that which will make a great deal of sense, but there are bigger underpinning issues, I think, that have to be dealt with as well. Critically, the value that we place on primary care, how we recognize it, and how we essentially encourage people to enter into that practice and essentially allow for that to be recognized as part of the critical part of the payment system.
So I'd love to jump in after Sheila. I mean, I think she's right. I can't tell you how many times, even in a conversation, within a very collegial group of leaders, I would be reminded of congressional jurisdiction. You can't talk about this connected to this because one is in one committee and one is in another. It made the top of my head come off, but it is a way that the agency is divided literally by Congress, by funding stream. So that's again why I think, you know, interest from inside. I would say one of the most successful efforts we had was around LGBTQ plus issues in the department. There was no office. There was no congressional mandate. There was no outside counsel except a group of experts who I assembled. And what we did is ask internally for leaders who were interested in these issues. And we had an interest from the President of the United States saying, go as fast as you can. This was pre the Supreme Court marriage equality bill. We had a lot of tools in the agency that we could move administratively. And he basically said to all department heads, go as fast as you can administratively. We came up with the outside experts advising us directly. And when I say us, it was senior leader. I mean, they met with me and gave me a list of, here are the top 10 things you could do, which included at that point, everything from changing hospital visitation rules, changing nursing home rules, looking at the definition of who can adopt kids, where foster. We would do the first 10. And I'd come back to the advocacy group and say, okay, what are the next 10? And we'd come, and by the end of a 3 or 4 year period of time, I mean, we had this enormous list of things that had changed. And it was, to me, an example of, you know, internal interest coinciding with outside experts who really could push the levers. And then department folks who came from, we wanted somebody from every agency represented, but we asked them to sort of self-select, knowing in that, at least, venue, it took some interest. But every department had, you know, somebody who was interested, somebody who was at the table, and they could figure out within their own agency what were the levers to push. So that kind of organic model, I think, can be enormously effective. And that's why I go back to internal interest kind of starts it. And so, and I'm saying you have a brilliant report here, engaging directly with the new leadership at HHS, finding out who is your principal champion. And it may be the new assistant secretary in health, it may be the secretary himself, it could be, you know, somebody else. But once you have that champion, then I think it's game on. And you can look at, you know, the opportunity to create across those agencies some real energy around who gets the report, what pieces of the report go to who can engage around it, do they need new money? You know, people can always find money for things they're pretty interested in. So I just think that, you know, that opportunity is there.
I appreciate that. And we had some advice to that effect too. Well, I guess where the committee was looking is that while there are opportunities for alignment of current interests and primary care, there's a longer term problem that might not be addressed by dealing with it in that way. So I'd ask all three of you, we have 1,000 whole county health professional shortage areas in this country that haven't changed in more than a decade. More of the counties in Kansas are HPSAs than are not. And that is actually getting worse. We're seeing an erosion of workforce, particularly in rural areas. We're seeing an erosion not just of physicians, but nurse practitioners and PAs from primary care. Its percent as total of healthcare spending in this country has fallen from 6.5% to 5% over the last decade. There's just this intractable problem of getting primary care to the level it needs to be to address health equity. How do we get that a champion in the federal government to create a sustained focus, even if some of the tactics or the battles are these alignments with current interest?
If I could go back to a comment that Linda made at the outset, which I thought was critically important. And that is to look at the structures we have in place today, to look at what incentives there are to essentially incentivize people to go into those areas, and look in part for local solutions. I had the great privilege of spending a fair amount of time in Kansas over my 19 years working for Bob Dole, as Kathleen knows. And, you know, you go into Osawatomie, Kansas, you go into some of those small towns out in the big first. And one of the things we have not done well at is recruiting people out of those areas who have an interest in returning to those areas when they complete their practice. The National Health Service Corps is great, but you put somebody in for a couple of years, you pay off their loans, and then they leave and go home. And so one of the challenges, I think, is to look to the people from those communities and see how we can, in fact, support them in their communities, whether it's practice and essentially education at the same time, and essentially incentivize them to go back home again. It's not the only solution, but it is part of how we think about rural areas. The socialization in those areas is challenging if you're the only provider in town, if you're covering all hours. I mean, you have to think about how we support people in those environments with the kind of tools that they need. But I think it's a multi-pronged solution. It's not a simple solution of core. It's not a simple solution of an FQHC. It's a combination of efforts. But I think the recruitment and the training and providing opportunities for people in those communities is an enormously important part of that.
Sheila, my family's from Larned, Kansas.
There you go.
Understand this well. So I don't mean to pick on Kansas. I just happen to know it. Not as well as either of you. So what you've just diagrammed is exactly where the committee was looking. Mm-hmm. The fact that training is at least part of training is in the domain of HRSA, but GME funding is in the domain of CMS, who has no authority actually to create accountability measures for training outcomes. Payment is at CMS, but in a different arm of CMS. Rural health clinics, teaching health centers, critical access hospitals, National Health Service Corps, they sit in different domains of different agencies. And that's what we were aiming to. How do we bring those discussions together so that we create more of a cohesive strategy for primary care? Where could that live best?
If I could, let me give you an example, hopefully, that might connect some of these dots. But it begins, I think, where Kathleen and Sheila both started, which is you need the president and the secretary to be motivated, interested, and committed. But one of the initiatives that I saw during my time that worked very well was the one focused on opioids and the opioid problem. Because there you had a whole department problem. You had FDA, you had HRSA, you had CMS, you had the Agency for Children and Families. All of them had pieces of equities in that. And it was really an initiative where, in a sense, partly organically, as Kathleen noted, people were given opportunities to work on the problem. But on the other hand, there were some metrics established, and there was literally a dashboard that showed up on the secretary and the deputy secretary's computer once a week. And there were literally meetings with the secretary's chief of staff and one of their counselors, along with me as ASPE, every week to monitor progress. And then every other week, we went to the White House to report on what was going on. And so it was really all about it. And that included doing things like working with the Hill to change the rules around prescribing by nurse practitioners and physician assistants. And in a sense, all the pieces that Sheila and Kathleen have talked about happening below had to be moved. But on the other hand, it was the accountability that the secretary and the deputy secretary watching every week that really made the trains continue to run. And they ran over, at least a couple of years.
It strikes me that's a brilliant example from Richard. I there's an opportunity, I think, as the hopefully the sort of pandemic focused discussion winds down a bit, to replace the urgency with this primary care shortage, which has been documented, but nothing's done about it, but tie it to care and equity. So there's clearly a declared interest in this administration and in Congress and in HHS with equity and disparities around health. There's a new interest in social drivers of health. Well, there can't be any better delivery system than a robust primary care system to do that. So I think there's a timeliness element about this report and where it's going to hit. You don't need more documentation of the need. You don't need more documentation of, the disparities and the issues. But I think, again, I wouldn't spend a ton of time trying to figure out where it lies. I'd spend more time lighting the fire under the leaders who need it to be urgent and a crisis situation. It could be, again, the new Surgeon General. It could be, you need somebody to say, I'm going to put this as part of my mission and declare this a health crisis and bring together the key leader and have the secretary, if it isn't the secretary himself, his tacit approval that that's going to happen. And they can figure out where this lies and how to get the people at the table and what part of Congress to bring in. But I think what's really important is that urgent need and capturing, I think, the, what's happening in the ecosystem outside. To make the Kansas situation worse, as you all both know, Bob and Sheila, we have not expanded Medicaid. So we are putting even the limited number of primary care docs in extreme jeopardy because too many of them are in situations where they're still trying to, they're called upon to deal with fully uninsured folks. We've had 3 hospitals closing. We got 2 more, I think, on the verge of closing. So that crisis is mirrored in the 12 states that haven't expanded Medicaid. So it's much worse in some ways than is being documented because we are crashing primary care docs into a situation where they can't sustain. Sheila mentions the payment for debt. Kansas created, when I was governor, which was 1,000 years ago, our own model of the National Commission Corps. We have that in Kansas. If you agree to practice primary care and it's been expanded to dentists and mental health professionals, we have a Kansas debt repayment program. We have a Kansas-based, and that has had some impact. It could be doubled or tripled by the federal government. That would be nice to mirror that. But I think, there's situations in our state and across the South where primary care is even in higher jeopardy because of the political Medicaid decision, which makes it almost impossible for folks to pay their bills.
Thank you, Chris. I suspect you had a comment for the panel or a question.
Yeah, thank you, Bob. One observation, I think, to go back to something that Sheila said, and it's not a response. It's your thoughts about how to weave this together. Fundamentally, these are questions about value, and much of value, particularly in healthcare, is determined by the Medicare fee schedule. Mm-hmm. So, which systematically undervalues primary care, and that may be why we got a little bit obsessed with that in the committee report, and thinking about how to actually make that happen. And it could be that this is I think, if I may use first names, Kathleen, you said that there were outside experts and advocacy, and there may be a need for more external organizing. There is a small group that keeps pointing at the Medicare fee schedule and how it perpetuates this. So you were talking about how we undervalue primary care. Much of that comes from the Medicare fee schedule. The other thing is to Kathleen and Richard's point. if health equity is this administration's LGBTQ or opioids, then that implies some, I guess this is more of a lament, some strategizing about who primary care's collaborators are around the health equity piece. Because as you point out, Kathleen, there are certainly many levers to address health equity. We've made the case for primary care, but if we don't have Medicaid access, what good is it? And if we don't have analysis around the non-healthcare factors and equitable income, housing, all the other things that drive it. So if we are going to capitalize on the health equity moment, making those sorts of external, I guess they're really advocacy collaboration decisions about who we're partnering with. Is it a primary care play with FQHCs, or do we have to think more broadly about who are our partners in such an effort? So I think there's a question embedded in there, but there's at least an observation.
Well, let me just take a small stab at, first of all, you can't, unfortunately, I wish you could do anything about the Medicaid expansion situation in states that haven't expanded. It is mind-numbingly stupid and all about local politics and nothing about even what the voters in various states want. So there's nothing an outside group can do. I think you can do something about building broad-based partnerships and primary care as a social determinant of health could be easily defined as one of those real drivers of health and wellness and measurement tactic that people look at as they look at what makes a healthier community. So whether it's, mayors or others, but you suddenly have an equity council or equity officers or whatever they're called in the White House, at HHS, and in other key agencies. And that's a group who didn't exist before and may lend themselves very well to this discussion and being champions of this discussion because they already are cross-cutting in a bit. And frankly, don't have a clear job once COVID begins to wind down. They're, sort of very talented folks, some of whom don't have a clear portfolio. This would be a great portfolio.
Thank you.
If you'll tolerate it, this is a really rich, important discussion. I want to pivot just a little bit to the other recommendations under this objective, namely around research. And Richard, I'll start with you. And my upfront question is, how do we make primary care research more sexy? But the underlying premise is, as with exploration, we tend to invest in moonshots in this country when we know little about the dark areas of our oceans. And primary care is like our oceans. We know precious little about these huge, vast parts of our ecosystem. Which means that we don't understand the presentation and evolution of disease. We don't know the effectiveness of treatments of patients in the wild who have multiple conditions. We don't know the importance of the role of primary care in dealing with social and behavioral drivers of health, except in very important pockets. How do we get more investment in primary care research from the 1% we now spend?
Well, I'm an academic, and I know one thing for sure, that academics respond to financial incentives. And if there's more money put on the table that's directed to that, you will see lots of people going there. And, it's that simple. And what I thought was interesting about the report was, in a sense, you left out PCORI. And again, if you're talking about sort of equity and sort of connecting all these dots, what better place than patient-centered outcomes to sort of start to build up more on the primary care side. Now, it's a little bit more directive because it's less command and control than, say, NIH or someplace else. But nevertheless, I think that it's a place that would organically be receptive to doing this kind of work. And so I think there's that. I think there's a role for philanthropy here. And I think there are some very big players in philanthropy trying to figure out what to do at, going back to Linda's comment, what to do at the community level. And, you see it with the Gateses, you see it with the Ballmers. And I think there's a role for philanthropy, not only in putting down money, but also serving as a bully pulpit, because lots of folks are listening to them these days.
Bob, if I could add to Richard's comments for a moment. One, he's absolutely right that attention will follow the money. I mean, if you move money into a particular area, whether it's at NIH or somewhere else, the research interests will follow the presence and the availability of those funds. One of the challenges, I think, is as we think about that, and as I looked at the report and the sort of implementation plan, which made an enormous amount of sense to me in terms of laying out the steps that one might take. I mean, we have focused largely, so far, not surprisingly, on the role of the administration and the role of the secretary and the role of an advisory council. I can't help but observe that there will be a role for Congress in this, in terms of establishing where their priorities and their interests are. And you see it in the context of the appropriations measures and the language that gets included in conference reports in terms of directing the NIH, or, I mean, diabetes is a good example, where the Diabetes Caucus is the largest caucus in the House. And the attention that has been given to diabetes in recent years is in fact a reflection of the fact, one, that it's present in so many people, but of the activation of Congress and making sure that it's clearly stated in the context of how we allocate resources. I mean, that's true in terms of ARC. One of the questions that you asked or was commented on by the report was the role of ARC and essentially how you can get ARC interested in these issues. ARC responds to, in part, its directive and its strategic plan, which in part reflects what the Congress has essentially said are our priorities, as it does the administration. The authorizing committees, as well as the appropriations committees, will clearly state we want money spent in this area. And what we saw in the follow-up to the ACA is when you see money being taken and moved around for other activities, what you need is the commitment of Congress to hold the department accountable, to hold them accountable for the spending of that money in very specific ways. I mean, the whole question of Medicare reimbursement is one that is constantly fought over in terms of the values that we place on certain services. So one can't ignore the role that Congress can play in establishing this as a priority and in essentially encouraging either the testing out of new strategies. I mean, we tried the bump up on the Medicaid side in terms of primary care. Apparently it didn't work. It wasn't adequate. So one has to step back and ask, all right, what are the right tools? But Congress has to be a partner in this in terms of establishing where, in fact, there ought to be incentives placed and how best to think about the allocation of those resources. You know, as is noted, it is also siloed. I mean, if it's, trust fund financed, it goes to Ways and Means and Finance, except part of it goes to the Energy and Commerce. If it's ARC, then it goes someplace else. I mean, you have to think through what those strategies might be as well.
So following up on Sheila and Richard's very thoughtful comments, it does strike me that the involvement of Congress is clearly important, and maybe, what you want to see if it could happen is the creation of a primary care task force, a group that might include members of various jurisdictions and committees, so it doesn't get immediately siloed into one committee or one chair or even one house, but people who may get briefed on the report, get briefed on the comments. I think that's for Congress. I think at HHS it's equally important that hopefully there is a resistance to the notion of let's create an office. In my humble opinion, that is the fastest way to silo an issue, is an office that has a limited number, 1, 2, 3 people, then it's somebody else's problem. Somebody else is thinking about that. They go to work on that. They talk to the outside advisory group, but they they often don't talk to anybody else and don't really have access to anybody else. So that often is a great way to kill a collaborative project is create an office, because I think it tends to do just the opposite of what people think it might. It doesn't elevate the discussion necessarily. It just often silos the discussion. The third area that I think, and it's talked about certainly in the report and the implementation, but I didn't see a lot of really deep attention paid, is I think one of the most critical things you talk about in this effort is diversifying the workforce and creating primary care teams. What does that look like? Who gets elevated? Is it, again, going back to the president's interest in creating this legion of community health workers? To me, they are an essential part of that team, along with nurse practitioners and docs themselves. But that's another avenue. I think that team concept, and particularly if this, second infrastructure bill gets legs and traction and begins to move, putting primary care teams into one of those definitions of who that is and what that means and where they would work and who they report to, that could be a huge, again, leap forward, because I think that's you're not connected to the community unless people get out into the community. That's a great link to docs. There are lots of models going on in various places, some hospital driven, some other driven, but pulling that together under an umbrella and the creation of primary care teams, I think could be a major way to hurdle this forward.
And this goes back to one of Linda's points at the very beginning, which is there is a piece of this that is in fact at the state level and at the local community level. But one of the issues that's clearly at the state level are these issues of licensure. And one of the things that we saw during the course of the pandemic was the stress on the systems to allow people to go across state lines, the limitations on practice acts in existing states that would allow nurse practitioners and others to behave in different ways and practice in different ways. And one of the tensions historically has been the role that the states play in licensure. And essentially what those rules are. And, this is one of those areas where we've had to step back and look at what that limitation, there are compacts in place in some cases, but not in all. The ability of people to move around and essentially provide services is again an area where it's both state and a federal, but the state has to be involved in that conversation in terms of looking for whether it's community health workers, whether it's the role of nurse practitioners, essentially what the scope is, what they're permitted to do, has to be, again, this conversation that engages the states.
And a very invisible piece of this puzzle that we tried to tackle a little bit but didn't make a whole lot of headway is the somehow the synchronization between skills acquired in the military and what happens when somebody leaves the military. Right now, there is no direct interface. There are all kinds of people who did medic roles, who were really on frontline healthcare provider roles during their active service. And when they come into the civilian world, it's as if no one has any idea how to deal with those skills. So there's a core of trained workers who are now in communities across this country, but who for whatever bureaucratic reasons can't get licensed, can't get recognized, can't transfer those skills, can't do that. So a dramatic way to increase some of the primary care workforce, and particularly the team workforce, is get that solved quickly. Get the military credentials actually recognized and synchronized with civilian credentials, and accelerate the access of folks to, do a profession that they were trained to do, like to do, are good at doing, but they have no way of practicing once they get out.
Let me take this back to the research question a little bit. Which because
that was the question.
But I think that you guys raise a really critical point, which is that there's a temptation to say, well, we need to do more clinical trials in primary care. And in fact, what Kathleen and Sheila are raising is saying there's a whole bunch of other research that needs to be done about what works, what the team looks like, where the successes have been, because we're a big country and there's lots of places where primary care actually works pretty well in this country. And figuring out the research that you need to do in a strategic sense that will allow you to answer the questions that all these other institutions need to answer to make better policy, I think is going to be critical. And so I urge you to sort of, if you're going to need a steering hand to guide this research, and I think it needs to be broad-based so that you don't get stuck into a simple biomedical model, because that's not going to solve the problem here.
It's almost a health economics model. And if you had that kind of data, you could do a sort of race to the top. You know, I mean, one of the things that happened in the education sphere was putting a pot of money. I mean, money does attract interest. Let's start there. If you want people to pay attention to something, put a pot of money out and say, these are the guidelines, this is what you want to do. But if you had a description of a primary care medical team and access issues and whatever, a sort of race to the top opportunity for states and locals to participate in that and to test programs and strategies could be very, very effective. What was shown in that Department of Education deal was even the people who didn't get the grant money began to totally reconfigure their education systems to try and get the grant money. So it has not only an impact on people who were able to get federal funds, but holding back some of the resources and then getting in line meant that people started doing business in a very different way. And that in and of itself was enormously, just the application process, if you will, made a big difference in the way people structured their education system and their goals and outcomes.
I mean, that's why CMMI was created on the health side, to do this type of thing.
That kind of demo, right.
And this seems like, it has the additional advantage that you're putting a new tool in the secretary's hands if they really want to pursue this, because if your demo is successful, it can become permanent.
So this has been really helpful. I want to go back to the beginning when infrastructure was not on the table when the committee was meeting, but we've been trying to think about how do we connect this to infrastructure, and that your specificity is incredibly helpful. National Academy committees have to walk a little bit of a fine line when it comes to congressional focus, because while we had a unique charge of coming up with an implementation plan, most of what we could emphasize had to be within current authorization, not on influencing Congress to pass new legislation. The two places we kind of really walked up to that line were the creation of an Office of Primary Care Research on the NIH campus and funding ARC's National Center for Excellence in Primary Care Research, which was authorized but never really funded to support primary care research. And Richard, their relationship with the PCOR Trust Fund has been really incredibly helpful, but still not sufficient to meet the needs of health services and primary care research. But you give us quite a bit of very, very good advice. We have a number of folks attending who've been putting questions into our Q&A box, and I wonder, Mark and Sarah, if you could help us sort through some of the key ones for the panel.
Sure. Thought I would start with one related to something Secretary Sebelius mentioned. So comment on Secretary Sebelius' example of addressing LGBTQ issues. How is the model that she described, that may be more organic, but is still has engagement of leaders and champions across agencies and from external stakeholders, different from the council, the committee's recommended Secretary's Council and an advisory committee, respectively? Is this an issue of who is sitting at the table? Please clarify.
Well, it isn't necessarily different. It starts at a slightly different place. It isn't something that an outside group is proposing and implementing regardless of traction in the department and in the White House. I would say ours flipped the other way. So it started with presidential interest coinciding with interests that I had, and then we went the other way. You've already got a sort of outside group of experts. You've got a clearly outlined plan. I'm just suggesting that if this is going to mobilize activity throughout the department, it's really important to have a champion or two, not just be proposed, but spend the time and energy figuring out in the new leadership and at the White House, who is it that can really connect with this, who's going to take this on as part of their own portfolio and drive it forward. And then I think it all can come together. But absent that, the report gets published, it goes on a shelf somewhere. Even if a council gets created, I don't see it as being particularly impactful without real engagement of internal leaders who are going to look at lots and lots of priorities. And, I think you just want somebody to make this their priority.
Great. So we have one other, and this is about kind of a community voice on the Secretary's Council. So how is the voice of patients and communities captured in the committee's recommended Secretary's Council? How do we ensure that federal primary care policy aligns with what patients want and need?
So in our recommendations, we had proposed a Secretary's Council and a federal advisory committee made up of stakeholders, including patients, that would help the council vet, or if not set, its priorities. But I have not seen in the council structure anything like that, where you have a council made up of agency heads and a FACA related to it made up of stakeholders. But I wonder if you all have examples where that might work, or thoughts about how that might work.
Well, I wonder, going back to Richard's earlier comment, or the comment made about PCORI. I mean, the whole purpose of PCORI was essentially to make sure there were patients' voices heard on a host of issues. And I wonder if there isn't an opportunity in looking at the work that PCORI does, look at the structure of the ARC research, and whether engaging them as well and determining whether there's value in essentially their ability to secure that information. Because I do think that will be critical, making sure, I mean, there are certainly advisory councils that are made up of patients, whether it's the prevention group or a whole host of others. But some of the, I mean, going back to the point about use the structures that we have currently and not create new ones if you don't have to. Look at what, if any, value that PCORI might add, or that you might be able to draw out of the work that ARC does. Would seem to me to make some sense.
In addition to that, it's one of the reasons I was kind of talking about the FQHCs, because of the composition of their board. They have to have community members as 51%. So having a few people who are literally driving healthcare in their own communities being representative on this broader group, I think is a way to bring not only a patient voice, but an experience. I mean, they're used to dealing with structure, they're used to dealing with organization. So having, folks who have done that kind of guiding medical work in their own jurisdiction elevated to, bringing that voice to a national situation could also be very helpful.
I can think of two examples. One of them, I think you started, Kathleen, which is the Alzheimer's a federal advisory committee that sat alongside a department-wide work group. Yep. And that was extraordinarily successful in terms of getting money over to NIH for this and actually moving the voices of caregivers into the dialogue.
You see why I always listen to Richard Frank? He also has a much better memory than I do. It's like, oh yeah, we did that. Yeah.
So this conversation has been so helpful to me because, the charge of having an implementation plan, when you're a National Academies committee, it's like, okay, who could drive this forward? And what we've talked about today is maybe our overconfidence in terms of what a council could do. And what I've learned most from your conversation today is that we need to hook on to stars. We need to hook on to energy that is already occurring. And so I think about a number of things. For instance, all of the energy around maternal
Yes.
mortality right now. What a partnership made in heaven to hook on to Underwood's initiatives in that area and his primary care there at the table. Also, chronic disease, the statistics about what happened to COVID and during COVID and chronic disease, are we somehow positioned, I think, to get on that? And then the whole thing about the Office of Equity. Do we need an Office of Primary Care if we can get on the equity energy and say this is where primary care can be most impactful? Behavioral health, clearly primary care is aligned with that. Aging and Alzheimer's. I guess if it's not a council, though, how do we mobilize a network, whether it's with entities like Corey or having something like a Research America that's focused on pushing primary care research to take advantage of aligning primary care up with what the nation is focused on, so that we don't have the situation with COVID where primary care was overlooked as a mechanism to help us do better with the COVID response. So you've got my mind really churning right now, which is what's great about these webinars. But really good dialogue and frank and candid comments today.
Well, Linda, you've touched on actually an interesting point. One of the questions I know you asked us all to think about is what linkages make sense and where there are opportunities for partnership. You're noting the sort of focus on maternal and child health, particularly maternal mortality. And the push to both extend on the front end in terms of prenatal as well as postpartum coverage, and the extraordinary impact that's had on people of color, on communities of color. The Momnibus, the work that Lauren Underwood is doing, and others. But it would seem to me there are some opportunities with existing efforts and existing connections to talk with some of the folks involved in that with the work that was done in this report. Because there are clear linkages in terms of how to essentially link up payment, link up coverage, link up focus on particular populations, dealing with equity issues where we know there was a disparate impact on communities of color against a whole host of issues, particularly maternal health. That's an example of one of the questions you're asking is, with whom do you partner? With whom do you take this report? Who can in fact be a champion? And that's what you need. You need someone to put a human face on this issue and basically become your champion, internal to the department, but also internal to the Hill.
Linda, I think what Sheila said is absolutely right on. It strikes me that, one practical suggestion is, and I know it's still pretty vague, but to look at what are the elements that, frankly, Democrats on the Hill are talking about in this broader infrastructure bill, because there is a lot that lends itself directly to the report that you're putting out, in terms of health workers, in terms of, beefing up access and, using telehealth. I mean, I think there's a way to take the energy that's behind an effort that's going to move, that already has, some attention and focus from the White House, from the department. I can guarantee you, whatever the outline includes will have the attention of the department across the board. It will have the attention of the White House across the board, and it will have the attention, at least, of the majority in Congress. So that's a synergistic effort that I think you want to really drill down on and say, all right, we fit in here and here and here. This is an opportunity to, rather than having primary care again sit separately, you say, we have a way of fulfilling some of the pieces of this puzzle by enhancing primary care, by paying differently for primary care, by having the health teams, and you kind of, I think, fit it into that wave of what is going to be discussed, what is going to be on the agenda, what's going to move, what already has the attention, and whether it lends itself then to, additional research by PCORI or NIH or anybody, or ARC or anybody else, additional funding from HRSA, additional, I think that begins to fall into place. But I think what we're talking about is kind of taking advantage of the wave that's out there that you don't have to create. And the worst thing is to stand apart from it and say, well, we're over here with our primary care report and this is going to be talked about. And I would fit yourself directly in the center of that discussion and pick out the places that the synergy works best, because champions will begin to present themselves. You'll have champions in the White House, you'll have champions in the department, and you'll have people in Congress who are standing up the way Kamala Harris and Lauren Underwood did in the, maternal health debate 2 years ago, and say, this is our issue. You're going to have folks in both the House and the Senate that say, we're going to try to carry this issue. And that's who you want to brief and focus attention on.
So,
Yeah,
so Kathleen,
I think the way that this gets tied together when you take that strategy is to have a robust set of metrics that cut across so you can keep track.
Yep.
Because
And you're bringing
otherwise,
us back to our topic. We're supposed to be the accountability group, right? So,
sorry about that.
good point. No, that's good. I'm just,
But I do think that to some extent, keeping people focused, you just need a formal set of reminders. And I think a robust set of metrics is a way to do that.
yep.
well, Richard, that was the source of our scorecard. But Kathleen, that was really helpful. What I hear is more of an ordering issue, that the first order of importance is to catch that wave, is to link up to the current priorities around equity, around infrastructure, and then the mechanisms that get put in place to make it happen. However you get the accountability metrics on the secretary and deputy secretary screen once a week. The folks who are charged with coordinating the stakeholder involvement, like with Alzheimer's, that happens more organically, but that perhaps our report could offer some suggestions about the structure then that is there to support the wave.
Well, the structure and as Richard said, the accountability. I think that what may happen is a lot of energy, but what you're going to measure, how you're going to measure it, who measures it, who's held, that could be, I think, a really important contribution from your team. We've looked at this. Here are the kinds of things that could help drive it. Here's how it cannot lose a focus over time. So those kinds of pieces of the puzzle, as opposed to saying this structure needs to be created, it needs to sit with this structure, and that's less important than what you're measuring, who's going to lead it, who's going to champion it. I think those two pieces can be really impactful from your group.
Well, Chris Kohler has a furrowed brow, which usually means he has a question.
My goodness, Bob. I appreciate the emphasis on the scorecard at the end and the reminder for us to do it. Something that I would say the committee worked with within the limitations, both our charge for implementation, but also the way that National Academy committees work is this notion of a strategy. Much of what catching the wave depends on is external organizing and advocacy. And it's worth naming, we alluded to it, but the primary care community is relatively fragmented right now. And so there is a little bit of external work that has to be done to organize this. I guess, Bob, since you gave me the floor, this is related a little bit to Richard's comment about research and the notion to make sure it's not a biomedical piece. I worry that workforce initiatives, although they have a long-term play, and God bless Fitzmullen and teaching health centers, which continue to go out, I worry that they don't capture the public attention. So, from an administrative standpoint, how do we, let's say we pair workforce with community health centers. I mean, what a great place to train clinicians. I'd like to train all primary care in teaching health center models in exchange for loan forgiveness. And Sheila will figure out how to make it local. So it's local folks that are getting trained. How is that enough to capture the public imagination? Is that riding the wave, or is that too technical an answer that doesn't deliver enough immediate return?
I think there's, part of it is the framing and communication. I just think of two recent ones, the opioid sort of NP and PA example. And the other one is what we're dealing with right now on nursing home and long-term services and supports, right? You have a serious workforce problem, and now it's getting a tremendous amount of attention. And I think that when you sort of put this in the right frame and make it salient to people's local communities, I think it gets traction.
Well, that's great. I can frame this. I mean, we're learning this in terms of vaccine administration. I was talking to the Health and Human Services Secretary in Michigan yesterday. She's got a problem in urban areas because she's got to find trusted spokespeople to reach out. And the most trusted folks are local nurses. So to your point, Richard, it's all about framing it.
And Sheila knows the most trusted workforce across the board in healthcare are nurses.
Yep.
Far more than any. I mean, that's why I think the team concept is so important to talk about. Because if people think this is all about, frankly, more docs, they're not as enthusiastic as talking about nurses and community health workers. And, I think that really captures a lot of attention and a lot of support.
I think it's also putting it, I mean, I hate to say this, but it really is putting a human face on the issue. And, reading it on the front page of the New York Times is not the same as having somebody show up in your community. And part of the challenge is making it real for the folks that are engaged, and how you stimulate that conversation at a state level, how you stimulate that conversation at a local level. And the FQHCs are a good way to do that because they are local, working with the states, working with the governor's offices, working with the state Medicaid directors, we eviscerated the public health system in this country over the last few years. So that infrastructure, which we now need to rebuild, would have been a source of a tremendous amount of support. But people want to see this at home. They don't want to just read about it or see it on the NBC News at night. What does it mean to me? And I think part of your challenge, Chris, is, how you bring this story home. How you bring, somebody coming into the community is part of your challenge, and how the member of the House or the Senate sees this when they go home, that it's raised at every single town hall meeting, that somebody raises their hand and raises this issue. That's when they begin to pay attention, is when they're hearing about it at home.
So the nursing home advocacy group, for instance, is one of the best organized, I think, across the country. And it's going to be much more powerfully organized after what decimated people in nursing homes. So, you look for partners who already have a voice and already are out there and can drive that portion of the message home. I think there are people who got organized around racial inequities about COVID, who could be very helpful as community leaders in this effort. You know, what does this look like? How do we get more Black and brown physicians, nurse practitioners, community health workers? How do you get, and that helps with maternal mortality, but it also helps with, you know, primary care. So, I mean, there are pieces of this puzzle where they're really organic leaders who have risen up and are beginning to speak about health issues in a very different way, representing underrepresented communities who often are not at the table. And that's what I mean. That's the wave you need. I mean, they're logical partners in this. They just don't know they are. And that's the goal, is to, you know, create that network and say, this is how your effort fits into this, and it lifts all boats. You know, here's how we can be helpful in this area.
Well, Sheila, Richard, Kathleen, thank you for this incredibly rich conversation. You've given us a lot to think about, and perhaps some new directions that we need to take. And Chris, Linda, thank you for helping get this conversation going and for the follow-up questions. Mark, Sarah, for your support of making sure that this happened. To our audience, thank you for joining this fifth and last of our workshop series. We have many questions left on the table that aren't lost, but we hope to be able to answer in other venues. Thank you all so much, and have a wonderful 4th of July.
Bye-bye.
All right.